Awesome. That's what I'm hoping for. Okay, very good. So, yeah, so we're going to talk about swallowing today, swallowing specifically with relationship to Parkinson's disease, obviously. Swallowing is a really complex topic and one that I'm quite fascinated with. And one of the things that I've been working on for a little while is an extra certification, getting board certified, we called it, board certified in swallowing. And that's just an opportunity for speech therapists to do a little more education, and it's quite a lot of work. So that's something that I've been working on professionally. So that's one reason I was interested in talking to you guys about this today and just sharing a little bit of what I've learned. Also, many of you know that my grandfather had Parkinson's disease, and so it's kind of a personal thing for me. And looking back, I was very, very new in my career when he was diagnosed with Parkinson's. And looking back now, I wish I had known then what I know now. So hopefully we can share some of this knowledge for those of you who are perhaps going through it. All right, so yeah, my name is Jennifer Howland. I know probably a good many of you. Got a master's degree in speech, got about 25 years of experience. I'm the team lead for speech therapy at AnMed Rehab Hospital, and I'm actually not there today. I'm on vacation, believe it or not. So I'm doing this from a hotel room, which is quite an interesting experience. Okay, so what we're going to do today is we're going to talk first of all about a normal swallow and what that looks like. And then we'll talk a little bit about a disordered swallow. And then we'll talk about dysphagia, which is a swallowing problem specific to Parkinson's, and then some of the treatment options that are out there. So if you look at this one here, this is just to get you a little bit oriented. This is the way we look at the anatomy when we are thinking about swallowing. If you imagine cutting, sounds kind of gruesome, but if you imagine cutting your head in half right down the middle of your face, and then looking at it sideways, that's what this picture is showing us. So of course you can see the lips there, the teeth, so the little pokey things behind the lips. You can see the palate is marked. If you take your tongue in your mouth and move it up to the hard part on the top of your mouth, that's your palate. And then you can see the soft palate back there. They don't have that one marked, but I always look at these and I'm just absolutely fascinated at the size of the tongue. You don't think of it as being that big, but it is. And in fact, the tongue is fascinating in and of itself. It's made up of 5 different muscles. And when you think about the movements of the tongue and the functions of the tongue, you begin to understand how complex it is, and why it has to be made with the different types of muscles that it's made with. You can see the nasal cavity up there. It's quite large in relationship to everything else, which is good, and we'll talk about why that's good later. The pharynx is just the back of the throat. The epiglottis is a little flap, and the epiglottis during the swallow comes down and covers over the airway to protect it. And the airway is the larynx there. And this isn't marked, but you can see the little kind of strips in there. Those are called the vocal cords or vocal folds. And we have the esophagus down towards the back, closer to your spine. The airway is closer to the front of the neck. Okay, now that we kind of have our bearings about us, let's look at a little video. I hope this works. And this is a YouTube video, so you're going to see an ad first. I'll skip it as quick as I can.
Jen, we jumped off your screen. I think that when she hit that clip, it hung up her phone. Again, back to use of technology. So I have her phone number. I'm going to text her real quick. So just bear with me.
Am I back?
You're back.
Okay. Sorry about that.
Well, like I said, if you have videos that, I mean, I can probably share them from my computer. I could just copy and paste the link if you want to do that while you continue to talk, and then I can share them.
Okay. Let me see if I can do that.
Gotcha.
Get back to my PowerPoint here. Okay, so what I'll do is I'll go back to that anatomy slide. Did you hear, were you able to see any of that video?
Now, as soon as you click to video, it hangs up your phone because you can't do YouTube and be on a call at the same time.
Technology. Okay. All right. Well, basically, that's unfortunate because the video has the guy that narrates it with a really great accent, and I don't have the same kind of accent. It's just not the same. But I'll just talk a little bit. I'll just talk you through the video, basically what it showed in animation. So obviously the food or the liquids go into the mouth, the chewing happens, the tongue gets the chewed up food into the center and kind of creates a little a bowl sort of, and the tip of the tongue goes up to the top of the mouth, and then gradually, kind of like a wave action, it pushes the food backwards, and then the base of the tongue lowers down, the epiglottis flips down. While that's happening, the larynx goes up and forward, and the vocal cords close off tightly. So you have closure, protection of the airway at both the vocal cord level and then at the epiglottis level, because it's flipped down, and the epiglottis is pulled open, and that just creates a nice little tube there for it to just slide on down. And that's the way the normal swallow works. All right. So dysphagia is, of course, a condition in which a person's ability to eat or drink is disrupted. And there are more than 3 million reported cases per year. Some of the complications of dysphagia include, but it's not limited to this. It includes coughing or choking, aspiration, and aspiration refers to when the food or liquids goes down the wrong pipe, goes to the airway. Pneumonia is another complication. Malnutrition can be a complication, as well as dehydration. There are a lot of different causes of dysphagia. Some of the causes are ALS or Lou Gehrig's disease, a stroke, especially if the brain cells that control swallowing are affected, or if a stroke happens closer to the brainstem. Almost always the swallow is affected. Parkinson's disease, multiple sclerosis, eosinophilic esophagitis, myasthenia gravis, scleroderma, esophageal cancer, esophageal stricture, which is just a narrowing of the esophagus that causes difficulty with the food passing through. So you can have a narrowing that is caused by scar tissue. You can just have a tightness in there. A hiatal hernia can cause a narrowing. Multiple different reasons why foods would not pass through the esophagus easily. And then xerostomia, which is dry mouth, and different diseases can cause dry mouth, and also a lot of different medications can cause dry mouth. So some red flags when we're looking for swallowing, or when we're talking to somebody in professionally, some of the red flags for us that make us say, maybe this person has dysphagia: coughing and choking, obviously, a recurrent pneumonia, fever spikes following meals, a wet voice quality when eating or drinking. So really, if you think about, sometimes you've talked with somebody, especially during a meal maybe, and you are aware that they need to clear their throat, that kind of wet sound is an indication that the food or liquids has gone down and may be sitting on those vocal cords, which is in the airway. And once it passes down past the vocal cords, that's when it is called aspiration. So if you're sitting there talking to somebody and they need to clear their throat, chances are, if it's during a meal, they may have a swallowing problem. If it's not during a meal, then it might just be that they have a cold and need to clear their throat, or some saliva needs to get cleared out of there. Another red flag would be a poor ability to chew the food, food left over in the mouth after meals, foods or liquids leaking from one side of the mouth or another, drooling, which is also poor saliva management. Maybe the foods are coming back up after or during the meal. And sometimes even people can have pain with swallowing. So those are just some of the red flags that indicate there may be a swallowing problem. So swallowing problems can occur in any or all parts of the swallowing mechanism. People who have missing teeth or no teeth, or maybe they have dentures. Dentures can cause difficulty, partly because, especially if they don't fit well, if they're sloshing around, it makes it really hard to control the food or the liquids. And the other part of dentures is that it reduces the sensation, because they're obviously covering up areas that you would normally feel with. So people may lose track of where the food or the liquids are in their mouth with dentures. Weak lips can cause dysphagia, and that is one of the things that contributes to drooling. Weak tongue. So you think about how complex the tongue is with all of its 5 muscles and all the different things that it has to do. And if there's weakness there, it may have difficulty moving the foods and the liquids through the mouth, or creating that little pocket that we talked about to keep everything in a nice cohesive bolus. Poor sensation, and that can cause food or that is left in the mouth or on the cheeks. It might coat the tongue, and that can increase the risk of aspiration. Poor airway closure. So we've mentioned how the vocal cords close and the epiglottis flips down to close, and you can have problems with both of those things not closing properly. The vocal cords, if you have a problem with the vocal cords, some people develop nodules on their vocal cords, which means that the vocal cords are not able to close tightly. And if they're not able to close tightly enough, then there's not enough air pressure below them. And that in and of itself can cause a swallowing problem. So we could also have reduced muscle strength that can lead to residue or leftover foods or liquids in the throat area. And then again, the esophageal stricture can cause foods to not pass well through the esophagus. So you suspect that you have dysphagia, or you suspect that someone that you love has dysphagia. What do you do? Well, call your doctor, ask for a referral to speech therapy for dysphagia, and the doctor might go ahead and order an instrumental exam at the same time. So when you get to the speech therapist for your clinical swallow evaluation, they will take a look at your mouth and your lips and your tongue and how everything is working. They'll ask for a medical history, and based on what they see, they may recommend different food or liquid consistencies. And we have recently switched, many facilities have switched over to what's called the IDDSI, which is a way of standardizing the different food consistencies so that facility to facility to facility, it's all the same. And we're still in the process of doing that. Some facilities are still on kind of their old system, but the new system has pureed foods. The next one, which is of course is like applesauce. The next one would be minced and moist. And I always tell people to think of cottage cheese, because cottage cheese has some lumps in it, but it also has that moistness to it that's intrinsic with cottage cheese. So that's the way all of the food should be prepared, is to look similar to that. The next one up would be soft and bite-sized. And the foods are in, the size of them should be about 1 inch square, and it should be really easy to mush them up. So even with your tongue, you might be able to mush them up and not necessarily have to use your teeth so much. And then beyond that would just be kind of a regular diet, but they might recommend that you avoid certain items, like, for instance, cornbread. Cornbread, I worked with a speech therapist once who said that cornbread was the devil. A lot of people have trouble with cornbread because of the little particulate pieces in it. It just really gives people trouble. Maybe they'll recommend that you avoid things like rice or pretzels. There's a story, the younger George Bush, when he was president, I heard there was a news story that he was eating a pretzel. He was sitting in the library, I guess. He was eating a pretzel and choked on it and passed out. And he was in there alone except for the Secret Service. But had the Secret Service not been in there to do the Heimlich, he might not have made it through the presidency because of those pretzels. So I suppose that after that, somebody recommended he avoid those pretzels. The liquid consistencies, of course, there's whatever, no restriction at all, drink whatever you want to. And then mildly thick liquids is something like tomato juice. Moderately thick is a little thicker than that. Extremely thick is more like a pudding consistency, which we really try to avoid pudding consistency. And in fact, I think it's important to note here that you don't want to thicken liquids without having an instrumental examination particularly with somebody with Parkinson's disease, because quite often people with Parkinson's actually do worse with the thicker liquids than they do with the thinner liquids. And that just has to do with the throat muscle strength. All right, so the speech therapist may also recommend safe swallow strategies. And those of you who've been through this have probably heard some of these. Small bites, small sips, sit up in a chair for all meals and snacks. It's really hard to swallow safely when you're lying down. Avoid distractions. And of course, like your mother always said, avoid talking when you have food in your mouth. Check the mouth for leftover food after the meal. Sometimes people with reduced sensation will have food that sits on the tongue or sits in the cheeks, which we call pocketing. And if you can just kind of suck that leftover food down or drink a little bit to kind of wash it through, or even swish and spit to get that leftover food, because that leftover food can be aspirated if it isn't taken care of in a timely way. We may recommend an effortful or hard swallow, and that's just simply putting thought into using extra emphasis into swallowing so that the throat muscles work harder to force the food to go down. That pharyngeal squeeze, we want the back of the tongue and the back of the throat to come together hard to force the food down the right way. We may recommend no straws. We may recommend something like a chin tuck, where you put your chin on your chest when you swallow, or possibly turning your head to the side. Especially that's usually used if somebody's had a stroke and has one weak side, then we may recommend they turn their head towards the side to close off that weaker side. We might recommend a throat clear between bites, or maybe every few bites, and we'll recommend consistent oral care. There are other things that we may recommend. Those are just a few. So let's talk a little bit about the instrumental examination. Quite often, if there's a swallow problem, you'll have one of the two types of instrumental examinations. And there's been a real push within the profession recently to not make too many recommendations without having these instrumental exams. And even though they're not necessarily comfortable for the patient, what they provide is so much information. It gives us a lot better understanding of how the swallow is working and what sorts of strategies are going to work the best. So that's why it's really, really important to have that done. So the first one is called the Modified Barium Swallow Study, not to be confused with the Barium Swallow Study. This is the Modified Barium Swallow Study. It could also be called a video fluoroscopy. Sometimes it may be called a cookie swallow test, and there are other terms for it in different parts of the country, you might hear it called something else. So this exam is completed in the X-ray department, and you have a speech therapist there, you have an X-ray tech, you also have the radiologist there, and there's a white paste or a liquid, which is barium, and it is spread on or mixed with various consistency items, and that is given to the patient to chew and swallow. And then that barium shows up on this kind of a moving X-ray image. If you look over there on the picture, kind of smack in the middle of the picture, there's a kind of a triangular dark shape, and that is the barium. So that is sitting right there in the vallecula, right, the little, which is the pocket right behind the epiglottis, the little flap that flaps down or should flap down during the swallow. So that's sitting right there behind it. And you can see that there's a little trail kind of going up the base of the tongue, and then there's another little trail of the barium trailing down towards the esophagus. So that's what we're watching for when we do a modified barium swallow study. We want to see what that is doing. Another instrumental exam is called a FEES, and FEES stands for Fiber Optic Endoscopic Evaluation of Swallowing. Now I have to tell you that fiber optic is a little bit, it's kind of going out, and the FEES that I use now, we don't use fiber optic anymore. It's a high-end distal chip, they call it, and it's just a better image, gives us a better image. So the way the FEES works is there's a small flexible scope. Think about a pencil. It's no larger than the diameter of a pencil, and but it's flexible. And on the end of that is the camera and a light. And we put a lubricant on that tube, and then we slip it into the person's nose. And I always think to myself every day, how is it that people allow me to stick something in their nose? Because that's not something that when I was growing up, I figured I would do, but here I do it all the time. But you think about that picture of the anatomy and remember the largeness of the nasal cavity. There's certainly enough space to put a little scope right in through there. And then that hangs right over the back of the soft palate. And you can see on the picture here, we're looking down. So it's kind of like a bird's eye view down into the esophagus and the airway. And this little kind of horseshoe shaped structure right there, that's the top of the epiglottis. And the green stuff is not normal. The green stuff is food coloring that's been put into probably some applesauce or something like that. We put green or blue food coloring into various consistencies or into the liquids, onto, a lot of times we'll use cracker, applesauce pudding, maybe a sandwich, and then just have the person chew it up and swallow it normally. And you can see when you look down into this picture, you can actually see the vocal cords. And through that, there's a black spot that is down into the airway. Now the esophagus is kind of on the upper part of the picture. Can't really see into the esophagus, but what's going to happen as the person swallows is that esophagus will be pulled open. So that's very interesting, I think. Okay, so specifically swallowing in Parkinson's. So recent research, and recent as in the study that I was looking at, was published in 2019. It indicates that as many as 82% of individuals with Parkinson's demonstrate signs of dysphagia. The swallowing deficits are often significantly worse in the later stages of the disease. And in Parkinson's, dysphagia can cause malnutrition, dehydration, or aspiration pneumonia. Aspiration pneumonia is maybe self-explanatory, but it is pneumonia that is caused from foreign material, foods or liquids or what have you, going down and being aspirated into the lungs. So if there's a history of recurrent pneumonia, particularly pneumonias that are in the bases of the lung, the right lower lobe pneumonia is the one that definitely raises the red flag in our minds, because of the way the tubes go down into the lungs. The right lower lobe is the one where most often foods or liquids are going to go if they're going into the lungs. Not always, but often. So research suggests that aspiration pneumonia is the leading cause of death in Parkinson's disease. So obviously this is something that we want to pay attention to. So while dysphagia in Parkinson's disease is often thought of as an end of disease complication, signs of oropharyngeal and esophageal dysphagia can often be seen earlier in the disease. And some of you may know about some of these things, some of these esophageal changes, including achalasia, motility dysfunction, reflux or heartburn, and oropharyngeal swallowing changes are often among the first signs of Parkinson's disease. And oropharyngeal is just a big word to say swallowing problems within the mouth or throat. So one of the first patient-reported signs of dysphagia could be excessive drooling, and that occurs in about 56% of patients. And also there's a direct correlation between drooling and dysphagia severity. So this is just another side view here to remind us of where we are in the anatomy. Again, you can see the large nasal cavity, the hard palate, the tongue, which is so interesting. And this one is kind of nice because it divides it up into nasopharynx, the oropharynx, and laryngopharynx. You can see those general areas there. Oh, and this one also points out where the vocal cords are. You might have heard this called the voice box. It's not really a voice box. It's just two strips of muscle, and we call those the vocal cords or the vocal folds. So what do problems swallowing look like in Parkinson's disease? So you might have some of these particular signs, swallowing issues with people who do not have Parkinson's, but these are the ones that we see most often with Parkinson's disease. The first one is tongue pumping, and that is kind of a rhythmic movement of the tongue, almost a priming of the pump to try to get that swallow to happen. So the food has gone into the mouth, or the liquids have gone into the mouth, and the tongue is trying to get itself going and just can't quite get the movement to happen. And then eventually it does. Slow chewing is another one, long oropharyngeal transit time. And so a normal in the mouth is less than a second, and after the chewing has happened. So we can have a long, that means the food can be held within the mouth, within the oral cavity for a long period of time. In fact, I know of one person who has freezing episodes. Some of you are familiar with freezing with other parts of your body. And this particular person that I'm thinking of has a freezing episode with the material still in his mouth. So that can last, goodness, it can last 30 minutes, it can last an hour, and he can't swallow it. He can't get the swallow to happen. And I think that the longer he holds it, the tighter his muscles get, and he's not letting it come out of his mouth, out of the front of his mouth. He doesn't want it to fall out the front of his mouth, and he can't get the swallow initiated, and so it just sits in his mouth. The saliva continues to collect, and you can imagine how miserable that would be. And then of course it affects his communication, because he's sitting there with a mouthful of stuff that can't go anywhere. And so he's resorted to head nods and shaking his head, facial expressions, hand motions, rather than actually using words, because he's got this mouthful of stuff. So some things that we figured out that help is increasing the stimulation of the foods that he takes in, like carbonation is one of them that seems to work really well. So if he's drinking like some kind of soda, Sprite or ginger ale or something with his meals, that seems to help. Another way that we can increase the stimulation is with something strong, a strong taste, maybe like lemon flavor. And then something else that seems to work for him is chewing. If he's chewing, then that seems to keep the muscles moving enough, and then it's like an automatic response to swallow. Now, if he's not eating, if he's not sitting at a meal and the saliva is just collecting in his mouth, I've told him he needs to just go ahead and spit it out because he's got to be able to talk. So that's one thing that can happen. Another thing that can happen is less control of the chewed up food, which we call a bolus. So the food is all chewed up, and then what do you do with it? There's sometimes, rather than having a nice cohesive bolus, it just falls apart and spreads all throughout the mouth. Also in Parkinson's, swallowing problems can look like food or liquids spilling into the throat sooner than they should. And along with that can happen a delayed swallow. So the food and liquids are going down and splashing down before the person is able to get that swallow started, and that can increase the risk of aspiration. Sometimes there are more swallows than normal needed to send the food down. So the person may swallow and not all the food goes down. They continue to have food left over in the throat. We call that residue. So they need to swallow again and swallow again and swallow again, just trying to get that food to go down. And that's when we know that the pharyngeal muscles, the throat muscles, are not quite as strong as they should be. Sometimes the throat can just not come up and forward as much as it needs to in order to effectively open up that esophagus. And then, like I mentioned with the other one, foods can get left over in the throat following the swallow, and that is called residue. Sometimes people feel it and continue to swallow to try to get that down. Other times people don't feel it, and then the residue is just sitting in the back of the throat, just waiting for the airway to open so it can be aspirated. And then, of course, sometimes foods take longer to move through the esophagus, and some people experience reflux or heartburn or GERD. So swallowing difficulties really can affect the quality of life. And one way that it affects the quality of life is many people have a reluctance to eat in public, and we're social creatures. And what do we do when we're socializing? We eat. So if you're avoiding eating when you're around people, that can limit your socialization and can increase loneliness and depression. And those are things that we don't want to increase. So this reluctance to eat in public might be because of drooling, it might be because of a slowness of eating, might be a fear of choking, or even with the feeding part of things, with the tremors that happen, the food and liquid spills. So as much research as we've done with swallowing, the pathophysiology underlying dysphagia in Parkinson's is not very well understood yet. And interestingly, we've not found a direct correlation between dysphagia severity and the extent of motor impairment or disease duration. So in other words, if a person is having a lot of trouble walking or with hand control, that doesn't necessarily correlate with how much trouble the swallowing, how severe the swallowing problem is. And pharmacological interventions used to alleviate gross motor features of Parkinson's that target dopaminergic depletion do not consistently improve swallow function. So that's a long sentence with lots of words. Just means that medications that are used to treat some of the other motor problems of Parkinson's do not necessarily help with swallowing. So what do we do? Well, there are some treatment options. So like I just said, the impact of the epimorphine and the levodopa on swallowing function has been investigated. So there are some studies that show that there are some improvements with swallowing outcomes, and others have shown that there's little change or even exacerbation, even a worsening of the swallowing. Another treatment is the deep brain stimulation. And that involves the surgical placement of electrodes in the basal ganglia and stimulation of the target nuclei, while improvements in motor functions such as gait, tremor, bradykinesia have been well documented. Evaluation of the impact of DBS on swallow function has shown marked variability across studies. So the studies are very iffy on how much this actually helps swallowing. Expiratory muscle strength training, or EMST, has been shown to improve swallowing kinematics and to reduce frequency of airway invasion or aspiration. So the EMST has shown promise in being a good treatment. And I don't have this one especially marked on here, but many of you are familiar with Lsvt Loud. And this is a therapeutic intervention that is targeted at modulating speech and voice function with high effort recruitment of respiratory musculature and vocal fold adduction. In other words, the patient has to work really, really hard on this one. So studies show that LSVT increases the opening and the length of opening of the esophagus. It reduces that residue in the pharynx, in the throat. And when they looked at coughing, they found that coughing was better with following the LSVT treatment. And we'll talk about coughing more in just a minute. And something to keep in mind with this LSVT is the significant dedication for this treatment. Because those of you who've gone through it, you already know that the therapy sessions are an hour long, they're 4 times a week, and it's for 4 weeks. So it's quite a significant therapy treatment. And then you also do 30 minutes at home practice every single day. And then when therapy is over, when that 4 weeks is over, it's 30 minutes twice a day. And that's necessary to hold on to the improvements that you made during that month-long treatment course. So another thing, really the most common treatments that we use are the compensatory strategies and maneuvers and the diet modifications. And these have been shown over and over again in studies to improve swallow outcomes. And of course, like we mentioned, they should definitely be looked at using an instrumental exam, the Modified Barium Swallow Study or a FEES, to check to make sure that they are as helpful as we think they are when we're first handing those out to you. So basically, pharmacological and DBS treatments do not provide clear improvements in swallowing or in speech, for that matter, in Parkinson's. And behavioral therapies are currently the most effective treatment for symptom management. That's those diet modifications or compensatory strategies or maneuvers such as the chin tuck. So let's talk about coughing for just a second. So when you think about coughing, efficient coughing involves the ability to feel foreign material in the airway. So you have to be able to feel that there's something there that shouldn't be there. And then it involves reflexively or voluntarily producing expiratory airflow forces sufficient enough to eject the material out of the airway. So in other words, can you build up enough air pressure below the vocal cords? Can the vocal cords close tightly enough? And then can you voluntarily force that out with enough force, that air out, that it removes whatever the material is that shouldn't be there? So inefficient coughing, on the other hand, has a name. It's called dysphagia. And that means essentially that there's not as much air force as there should be when the air blows out. And this can be due to reduced strength of the respiratory muscles, the breathing muscles, and it can also be due to poor motor coordination. So inefficient coughing is common with Parkinson's disease, and it is associated with dysphagia, swallowing problems, and aspiration. You can imagine why that is. So hot off the press, this is brand new areas that we've been looking into, which is exciting because this means that we're starting to get somewhere with our research. The new treatment that was looked at in this study that was published in 2020 did 4 sessions of RSCT, or respiratory swallow coordination training, and VCST, which is voluntary cough skill training. So basically they haven't come up with a really good name yet, so they just put out a description of it. So the study that I was reading was published in 2020, and this showed significant improvements in swallowing safely, swallowing safety, swallowing efficiency, overall swallowing function, and quality of life related to swallowing. So it's very exciting, but I do want to mention that more study needs to be done, and they need larger sample sizes, and the treatment protocols are still being developed. So I just wanted to mention, last but certainly not least, is the importance of oral care. It's really, really important to keep the mouth clean, keep the mouth free of residue, bacteria, because if you think about somebody who's aspirating, and people can aspirate and do often normally aspirate saliva in their sleep. So you may remember a few years back, there were some news articles that came out talking about the relationship between brushing your teeth and cardiac issues, heart issues. And we're thinking that a lot of this has to do with when you're aspirating at night, because we all do a little bit with your saliva. If you still have residue left over in your mouth, or if you have bacteria of some sort left over in your mouth and you aspirate, it goes down into your lungs, then that can cause pneumonia. It messes up the homeostasis, or kind of the balance of the body. So definitely keep those dentures clean, and before you go to sleep at night, brush those teeth, and use good mouthwash. And if you have trouble with some of that, then your speech therapist can talk a little bit about other options. You can get little suction machines to suck it all out, kind of like what they use at the dentist office, and that works pretty good. All right, so we're now at the point where we have time. I might have run a little bit long, but we have a few minutes for questions and comments. Do you want to go ahead and stop my sharing?
I just did stop your sharing. So we've got everybody on the screen. You know, one of the things that why I appreciate this presentation, like I said, we had it done a couple of years ago, but it's been a while. We mention all the time the need for physical therapy and speech therapy and occupational therapy. And I think a lot of times people associate speech therapy only with, well, my speaking is fine. I don't have a problem speaking, so I don't need to see a speech therapist. And there's so much more involved. And so that's why I think this particular education is so helpful.
Yeah, I hear that every day, multiple times a day. Why are you here to see me? Because I talk just fine.
Right. Well, everybody, I would like to, first of all, thank you so much, Jen, so much information. What questions does anyone have? Remember, you're muted, so if you would like to ask a question, you'll have to unmute to do so, or if you'd rather put it in the chat, we can have that there too. But we have a few minutes left if someone has a question for Jen.
Hello.
Hello. Hi, Diane.
Can I hold it? One thing I've noticed that Tim is doing that is new is when he talks, he holds his jaw, and it distorts his speech somewhat. It's something I've noticed. It makes his speech quieter and somewhat distorted when he speaks. And along with that, he will raise his neck, his chin, and he'll make a Parkinson's face, but it pulls every muscle in his neck, which I'm wondering if might lead to future problems with swallowing. And then I have, concerns with that as well. Although he's not having problems now, I do notice he is eating a lot slower, which was on your list. And probably that was the only thing that I see as far as he does not like to eat in public, but I understand that, with the tremors and so on. But he does have, a slower eating habit. But this concerns me when I see how tight his muscles are in his neck.
But a lot of it comes not when I'm having normal conversation like right now.
But
It'll
concentrating.
come when I'm trying to do a task.
He's
I,
concentrating
get-
very
I
hard.
call it my monkey face,
Yeah.
okay? Because I start to get like this, okay? And my jaw gets clenched, my upper lip gets tight, and it's a very distorted.
Right, very distorted. But he's very, very tight in the neck muscles. But I do notice he clenches his jaw when he talks quite a bit. So those are a couple of concerns that I have that I've noticed that is new with Tim. So
Yeah, I can certainly imagine, you know, when you're working on something really hard and you're concentrating, that you could kind of clench your try to do what you're doing.
Oh, we're watching a Zoom meeting. Hold on one second.
I guess
I don't
my
know
question would lead to swallowing problems, I guess, or, you know, problems with neck problems.
I don't, in and of itself, the tightening in and of itself, I don't think will cause swallowing problems. I could see how the tightness, how you could be concerned about that. I think that the bigger concern really is just the weakness. If there's weakness inside, that's where the trouble's going to come from. But if you're doing this while you're working on something, I don't think that in and of itself is going to cause swallowing problems or speech problems.
Can you hear me?
Yes, I can.
I've been recently diagnosed. Would it make sense, or is it advisable to get some of the testing done?
Yeah, it doesn't hurt to go ahead and get an evaluation, to go see a speech therapist. They may go ahead and start something like LSVT with you, because the sooner that you go through that, the sooner, you know, we can get a baseline measure, and then you can begin to do the exercise, and you can do that exercise from here on. And if you start the LSVT early, then and you keep up with it, that's really, really important to keep up with it, then you can avoid or at least push off some of these swallowing problems and voice problems that are kind of typical with Parkinson's. Just like
something that we've heard so many
exercising.
times, you know, Jennifer, from everybody, all the different therapists, is don't wait until you're having a problem. You know, get the education and get a baseline and start doing the exercises and practicing, so that you can not necessarily prevent it from ever happening, but certainly provide a much longer period of time where it's not so much of an issue.
Mm-hmm.
Thank you.
Anybody else that is on that wants to ask a question?
There's a question on the Heimlich Maneuver. Where does that fall into the scheme of things with what you're talking about? Is that just an absolute last resort?
Yeah, hopefully we don't ever have to do that. But you know, certainly that can happen, and I think that's what they had to do with President Bush, because I think Secret Service had to come in and do the Heimlich Maneuver and clear that pretzel out of the airway. Really, you know, you think about swallowing, choking, and our automatic thought is, okay, Heimlich Maneuver, but really and truly, we don't do that very often. It's pretty, in all of my years of treating people with swallowing problems, I think I've only done it once. I've only been there one time. I didn't actually do it, but I was there with a person one time. And so that's, hopefully we can solve things beforehand, but usually you don't have, when aspiration happens, usually it's not completely blocking off the airway. It's usually like bits are going down, or little, so not an entire swallow of water, but maybe a tiny bit of that liquid is going down. And so it doesn't completely block off the airway.
Mm-hmm. Mm-hmm.
Yes, Steve.
I have a question. Why no straws?
Good question. And that is a little bit variable between people. Sometimes people do better with it. And it can be really helpful, especially with people with tremors, to use a straw because it kind of cuts down on the mess. But the reason that we like to stay away from straws is because if you're having a swallow problem and all of this movement is slower than normal, then you suck the liquid through a small tube. There's a certain amount of force that has to be used. So you're pulling that liquid up and you're speeding that liquid up. And then it can fly into the mouth, fly down before you have a chance to gather it up like you need to and get that swallow started. And so that's why it increases the risk for some for aspiration.
That seems to make sense. I've been using straws to take my medication, the liquid, so I'll look at that.
Yeah. And again, it's not 100% across the board with every single person. Sometimes it's okay.
Thank you.
We have just a few more minutes here. Is there anybody else that has a comment or question before we sign off?
I have a question.
Yes.
When I get up in the morning, my tongue feels like it has a film on it. Could that be related to drooling?
I would look at a couple of different things. The first thing I would want to do is see your tongue and see if you have a white coating on it. That would be my first question. A white coating on your tongue is likely thrush, which is yeast, and that can cause that feeling. It's really common with certain kinds of medications or just in general when people are sick. We get that. And that can be taken care of fairly easily with just a medicated mouthwash that your doctor can prescribe for you. The other thing I would think about if that's not it is it could simply be dry. Like you might be sleeping with your mouth open, and when you sleep with your mouth open, that causes kind of the moistness in your mouth to go away and get less moist, so it's more sticky. So that may be what's happening.
Okay. And a follow-up question. Do you have a list of medications that cause like the dry mouth or the drooling? Because when I go to my family physician, he says, well, it may be some of your medicines, but he can't tell me which ones.
You had to take them.
I don't have a list handy, but I could get one, and you could also Google it.
That's a great question. And I think that might be something, you know, Robin's on this call too, that we can maybe work together, Jennifer, and try to get a list of things that we can put on the resource page that might be helpful for people.
Sure, absolutely.
That'd be great.
Well, we'll work on that for you, Loretta.
Okay, thank you.